90% of African traveling for treatment. South Africa used to receive 12% of travelers. Now it receives 2%. The country that has become the leader is India. And the reason, Mercy, is if you ask all the families, you also told people that we were all involved in these costs. They will tell you there are only two things that make them travel to India: cost and quality. So I wanted to get back to our discussions here. For us to be very impactful for the entire country, we have to discuss two things separately: what we pay and how we pay. There's no doubt that risk pooling and pre-financed care is a great way to make sure that you are not burdened at 12 at midnight or 1 a.m. when you are getting admitted and you get straight through. You've heard people saying hospitals asking for deposit before they give you a bed. You've heard that situation. This is what we're trying to say, how we pay. If our families with private sector and government had everybody covered, then no matter who needed care will get care, because it is the how we pay. That's the risk pooling and that's the UHC. But one thing we still haven't touched properly is what we pay. Did you know that you take any bill in Kenya, take outpatient bills, no matter where you are, in which county, you will find that the lion's share of your outpatient bill is pharmaceuticals, is the largest. You take a hospital bill, no matter where you go in Kenya, public or private, you will see that specialized services and again pharma will take a lot of care. And if you're in theater, surgical cases, you will see. So that's, people are specialized, they know how to do this analysis. Now let's go a little bit deeper into the largest reason why healthcare is expensive. 70% of every drug we use in Kenya is imported. 70%. Uganda is 90%. Go to Africa and list these countries in which most of the pharma is imported and what is made locally. And then on the other side, you do cost of care to the citizens. Input costs matter. That's what I was trying to show you, and that's why I was nodding, and why when Rashid was speaking, it matters, because when you buy, that's your cost price, and then you have to sell not only the cost of what you buy, but also the people delivering. So people and inputs are the largest contributors of every family's cost of healthcare. In India, for example, now I'm using that country as an example, when you have higher supply, it's a supply-demand ratio. When you have 1,000 cardiologists, how much is the consultation a cardiologist will charge? And when you have in Nairobi 10 cardiologists, what would they charge? You see the difference? If you take oncology, right? If this is the same oncology and we have 5, and in a country you have 500 and 5,000, do you think that oncologists will drop their price? Yes, because if the oncologist doesn't drop the price, nobody will employ the oncologist. But here, if he's the only 2, or that neurosurgeon you talk about in Mount Kenya, and he'll say, my salary is 5 million. Whether you want to employ me or not, it's okay, but there's somebody else willing to employ me. Take it or leave it. So supply-demand is a serious conversation that we must have in this country. If we continue to make great healthcare workers, great specialists, institutions like these are all contributing in reducing cost of healthcare. We need more specialists, we need more health workers, we need the supply to go up, and locally we also need to start bringing in locally manufactured products, generics. So healthcare is an interplay between supply and demand. And we should, and it's not a Kenyan conversation, Mercy. If you look at the US right now, the largest topic that these political parties have is cost of healthcare, Medicare and Medicaid. If you look at UK, Everything is about NHS. So if you see where Kenya is going, and we've seen what other countries have gone through, if we don't start really dealing with cost of healthcare under the supply-demand mix, we might end up in a difficult situation like the developed countries have. Thank you.
Okay. Thank you, Dr. Amit. Though sometimes I feel Kenya is unfairly compared to, say, India. And it's good you brought up that conversation, because if you look at the population of 1 billion plus, and Kenya is 50 million, we are unlikely to get 1,000 cardiologists even in the next, 10 years. So sometimes that comparison is almost like apples and oranges. So is there a country or somewhere Kenya can benchmark with? I know you have vast experience across the African continent and beyond, that, we can almost compare when we are thinking about how to price our healthcare and the quality that we are offering.
Right. No, that's a very good question. I'll add one more point. If you look at China and you look at India, India's population and Africa's population almost similar. India's got 15,000 factories producing medicines for its people and maybe around the world. Africa has 500 factories for the same number of population. So again, if you do like-for-like comparison, you could take the whole continent and India and start comparing, and you can start multiplying the same population you gave us and see where we're going. But we have to do more. I think we have to do more in Africa to produce our own academic talent, and we have to try and produce more for the consumption of the ailments and diseases that we suffer in Africa. To your question, if you benchmark Kenya, I think we're doing pretty well. I think if you talk about the 5 or 10 hotspot countries that have the best dual system of healthcare that looks after its population, and I'm calling it dual. We are moving away from Europe. Europe and Canada are singular. There is no way that we're going to move from a public and private effective mix to make Africans live longer. So if you look at Kenyan's dual system and you benchmark the other hotspot countries, the close ones come to is South Africa that have an effective dual system. The other one is Egypt, again with a dual system. And you look at the health indicators, and you look at affordability, and you look at communities that continue to consume healthcare within its own country. I think it's really close to watch them. Ghana and Rwanda are worth looking at when it comes to UHC, because they've got an intentional mutual scheme and NHIF, and I'm sure team has had a look at that. So if you look at how people pay for healthcare in Africa, I would say we should look at Ghana and Rwanda. Mm-hmm. And if we look at what people pay and quality, we should be looking at South Africa and Egypt, and Kenya fits right smack there.
Okay. I want to bring in Dr. Lishenga. Can provide a microphone to him. And also Dr. Wangia. I'm just calling them out so that we have a smooth transition. Dr. Wangia is just here. We were waiting for you so that you give us, Dr. Liz Wangia is a health finance specialist at the Ministry of Health. So I wanted her to give us a breakdown of what makes up the cost of care in Kenya. And I know she has worked tirelessly to break this when she was working through to come up with SHIF, what Dr. Olwenyi was talking about. So what are these components that make up the cost of care for us in Kenya, and why do we see that it's up? I know we've had a conversation about the inputs, the personnel, so you can just break that down for us.
Okay. Thank you so much, Mercy, and for the delegates or members present. I'll answer your question by just touching on what you call the total health expenditure. And basically what the total health expenditure means is that these are the expenditures of health from different sources, and they target different interventions. So this starts from curative services, preventive services, promotive services, and basically not necessarily the cost only in hospitals. I know many times when you think of the cost of healthcare, we just think of what is the cost in terms of the cost within health facilities. So looking at the total health expenditure, we have what is incurred in the health facilities. These are the direct costs, and that is what we mainly measure. Direct cost is what really goes into the cost of seeking care. Then we have indirect costs. Actually, we don't usually measure indirect costs when you talk of the total health expenditure. Otherwise, the health expenditure will be way, way higher than what we are talking about. And when we look at indirect costs, it's mainly looking at what it takes, say the transport costs, right from the time a patient and their caregiver leave home. You are looking at the time they have lost. Probably they would have been earning wages. So you look at that cost. What does it take to the fact that they have come to seek health care, they have lost wages. How much is that wage? Then we look at other costs such as public health interventions. When we are looking at the interventions within the community that prevent diseases, the water and sanitation, all those are considered costs within health. So it's usually good to look at it wholesomely and not necessarily just what is incurred within the health facility. We also have insurance, because insurance cannot be smartly placed within either direct or indirect costs. And also administrative costs are one of the costs. But just as one of the speakers spoke before, when you look at what are the top cost drivers in health, mainly are around health commodities, and also because in terms of, health commodities, then in terms of also infrastructure, equipment, and innovation, health keeps changing with time. For instance, an equipment won't last more than 7 years, 5 to 7 years before it's rendered obsolete in terms of technology. So if you are to invest in health, it means that every 5 years or so you have to invest in new equipment, new technology, and that comes with also new training. Right now we have a cyber knife at KU, KU Teaching and Referral Hospital, but we don't have the skill set to actually operate it, yet it's quite an investment. So any change in technology also comes with that change in, specialization and all that. So that's what I would call in general as the costs when you look at the cost in healthcare.
Mm-hmm. Okay, thanks for that, Liz. We'll be coming back to you. Dr. Lishenga is on this side. I just wanted to ask him, because Macharia mentioned about, where the money from insurance goes, where the money from NHIF goes, and there are facilities that get, almost the breadcrumbs of the insurance money. Are these the facilities you represent? And I'm asking Dr. Lishenga because he's the founding chairman of Rural and Urban Private Hospital Association. And I know he's been very vocal about, where the money is being spent. So is it an issue of cost at these facilities or an issue of quality? Why is it that you're missing out on the bigger cake?
Is this a yes or no question? I mean, if it's a yes or no, then I would say yes. You want me to stand up? Thanks. So I don't know, team, Dr. Olonyi will be unhappy with my answers, but I have freedom to speak at Aga Khan. Yeah, well, it is true that many of the facilities that I do represent, to use Macharia, my friends, an example, 100 hospitals on the NHIF panel account for 70% of the payout. This is very true. The NHIF database has close to 8,000 facilities. So if you think about it, 7,900 facilities share 30%. Now, you ask yourself, where are these facilities? And your answer is invariably rural communities. So the vast majority of Kenya's population, which is still 75% rural, who depend on these facilities, experience just about 30% of what you can call NHIF payout. And maybe in my view, that explains why every time you survey Kenyans, they express dissatisfaction with NHIF. They feel that, and this is the experience now, payments, monthly subscriptions to NHIF have been falling. And if you ask me, part of the reason is lack of public confidence. That 500 bob that we were saying is now going to move to 2.75% for equity, for a vast majority of Kenyans, that 500 bob is already too much. And why is it too much? It's too much because it is not commensurate with the service experience that they get. And part of the reason why RUFA came into being was this huge yawning gap between what I would call urban care and rural care. And one of the things I pride myself with is being able to give voice to those who are in rural areas. I'll give you an example. I ran a facility in Njoro for some time, about 6 years. Njoro is in Dr. Olonyi's neighborhood. It's about 25 kilometers southwest of Nakuru, 180 kilometers from here. It's a rural community. And I can tell you, it's just 25 minutes drive from Nakuru. It was almost impossible for me to get an obstetrician to come and do a hysterectomy for a mother with postpartum bleeding. The reason was structurally, and we've tried to address this over the years, that physicians like myself, surgeons, we are rational beings. We follow the money. We are very rational. If you put money somewhere, I'm going to offer my services there. And we haven't put enough money in rural health. Even in way we structure contracts. For example, I'll give you, if you're a rural facility seeing teachers, you'll be told, we will pay you an outpatient fee of 1,500 per visit. For the same condition, malaria or flu. Same teacher with malaria or flu visiting an urban hospital gets compensated. The hospital gets compensated 3,500, 6,000. Of course, the argument has always been cost of living, etc. But what that does directly disincentivizes healthcare professionals from providing care in rural areas. And that, in turn, disincentivizes investors from setting up healthcare facilities in rural areas. So my concern is, even with the reforms we are doing now, I still don't feel we are doing enough to provide care at the bottom of the pyramid, despite the fact that our agenda is bottom-up, right? So I still think that we need to do much more, invest in rural health, which invariably means primary care. Primary care, first contact care. It seems that as a nation, we are a lot of focused on advanced care, but 80% of people seeking care just need to see a family doctor. They don't need to see advanced care. So there's this dichotomy, Mercy, that I think we need to address.
Mm-hmm. Dr. Olwenyi, you look like you're ready to respond very quickly to that.
Dr. Brian is my colleague, and for those who don't know, Dr. Brian used to in a different life, actually used to work in our facility. So he's somebody I know very well. Brian, on the contrary, I thought you were going to say, I don't know how you're saying I'm not going to be happy with what you said, because what you said is exactly the reason why we need to change from NHIF to the Social Health Authority. This, I was on that side of the fence. I got I got in this position because of being an active critic of NHIF and how it was structured. So all the solutions that we have in terms of changing our healthcare financing architecture are meant to address those problems. You talked about primary healthcare. We're spending too much money on curative care. And the reason is because that's where the resources are deployed. There is no insurance company that's going to be sending anybody money, including NHIF, to pay for preventive care or promotive care. So we're waiting for people to get sick. At that point in time, we're spending much more money, isn't it? So we are taking this further down the spectrum and saying we want to invest more in preventive and promotive care. And that's the reason why the Primary Healthcare Fund was set up, to take care of people's bills in primary care facilities, levels 2 and 3. That is the main reason why it's funded by the Exchequer. That's the main reason why nobody has to pay any money. All you need to do is register and not be a paid-up member to be able to access those services. at levels 2 and 3. The same thing about the Social Health Insurance Fund, difference from NHIF. We had got too many packages. We had got a contribution structure that was complicated. We had got too many benefit packages. Believe it or not, there were over 90 benefit packages and schemes that were run under NHIF. One was a national scheme. The others were the so-called enhanced schemes, where employers say, I want an additional benefit for my employees. And that additional benefit meant that they're paying an additional premium. The first problem was that premium was most of the time underpriced. And that's why you see there has been this clamor that people saying the Social Health Authority must still administer schemes for civil servants, for counties, and so on. The reason is they were getting a very good deal. The premiums that we were paying were underpriced. When they went to my colleague here on the side, the premiums were raised. Well, they were told a certain premium. They came to NHIF, and because NHIF is quasi-government, government was arm twisting NHIF into accepting premiums that didn't make sense. So the loss ratios were impossible. So what happened is these schemes were cannibalizing the national scheme, so the scheme was not sustainable. All right? So those are the things that we're trying to cure. We've got a standard benefits package now, which is going to be one package. And that's why we've involved people in terms of the development of this package. It is going to be standard, so everybody knows what they're entitled to. They can't be denied that. One of the reasons why NHIF got bashed about not being fair is that you hear somebody has been taken for treatment to India. But it's because they've got an enhanced scheme where the employer is making an additional contribution. You come as an ordinary Mwananchi, you say, even me, my child is sick, has got cancer, needs to go to India, and you're told, India is not for you. All right? You see that discrimination component. So one thing we're doing is to standardize that benefits package. It is going to be made public. Everybody will know what they're entitled to. We're removing the human discretion about it, isn't it? We are opening it up so that people can go to, regardless of any facility you go to, we are going to provide that benefit regardless of whether you go to the high-end hospital or you go to the basic one. If you go to one which charges a much higher premium, then you have the option to kick in complementary insurance, or you have the option of being able to pay for it out of pocket. But the objective is everybody should be able to get the care they need at a facility somewhere within the country and within their locality. So a lot of the issues that Brian has raised is the exact same reason why we decided to move from that previous dispensation to the current one. And that's why I expect Brian, as being somebody who is a leader in this space, to support this initiative because it is addressing the same problems that it was designed to cure. When you talk about additional out-of-pocket expenditure, for example, that's why the Emergency Chronic and Critical Illness Fund was created. We've got a lot of people who, for example, have accessed their benefits under NHIF, and they run out. Now we're saying there's an additional wallet which people are supposed to source funds from. So you become moved from that fund, if you're a paid-up contributor, to the next fund. The issue of emergency care has been a big problem for facilities, especially private facilities. Section 43(2) of our Constitution says everybody has got the right to emergency medical care. It didn't go far enough because it didn't say whose responsibility is it. And especially for those in the private and faith-based sector, the thinking was, I can't go to an accident scene and help people and evacuate them and bring them to my facility, and then after that again incur the cost for their care. The addressee of those rights is the state. And therefore that is why the government now is fulfilling that mandate and saying they are setting aside funds from the exchequer to take care of those emergencies within the first 24 hours. After the 24-hour period, however, you need to be a paid-up member to be able to continue to access those benefits. But those are the changes that are being made in terms of curing the problems that were there in the health sector. Thank you.
Thank you. Brian, sorry for putting you on the spot. But let me come to Rashid, and listening to what Brian has said and the other experts in the room. How can the private sector, especially you representing what we consider high-end hospital, work together with government to make healthcare more affordable, such that anyone can come in and not feel like they need to sell some property to access that care?
I'll pick up the point where Dr. Thakkar left from. It's all about economies of scale and the availability of the specialists. Aga Khan University Hospital is the only private hospital that is a teaching hospital. So the example that our colleague mentioned, that there are no specialists 25 kilometers from Nakuru. Why there are no specialists? So what are public institutions or private institutions doing to train the doctors? And when we talk about doctors, it will be a longer answer, but let me do it. When we talk about doctors, doctors can be categorized in 3 levels. So there is a first degree doctor, MBCHB. Then there are doctors who have done the residency program, masters. Then the third level is where they have done subspecialized training, becoming a neurologist, becoming a medical oncologist, becoming a neurosurgeon, etc. Aga Khan University Hospital is playing its role by training the doctors, not only at the first level, the MBCHB, but we have been doing the residency program, and now we have very recently started 12, 13 fellowship programs in advanced training as well. And now what is the idea? The idea is that we have to have enough specialists in all counties of Kenya, so there is no mother who is struggling 25 kilometers from Nairobi for a procedure because of the lack of the specialists. So those trained doctors within the AKU, I don't think there is any county now in Kenya where there is no AKU graduate doctor. So what we have, and when we train these doctors, we don't bond them. They are free to go and practice, right? And our hope is, and our prayer is, that over the next few years, these specialists who are locally trained, they will go out in those counties and provide the services that we want. So that will answer some of the supply side challenges. The example that Dr. Thakkar gave, that if you have 10 cardiologists versus 1,000 cardiologists, the economies of scale is different. Because right now, a lot of patients are chasing very few cardiologists. But if there are many cardiologists, then the prices will drop. So that's one part that the private sector will play. The second part that the private sector will play, the example that you mentioned about, someone mentioned about India, there is a documented study. $7 to $8 billion annually is going to India in terms of medical tourism. That's the wrong word, but let's stick to it. $7 to $8 billion. Now, if you ask yourself, who is going to India to get healthcare and giving $7 to $8 billion annually? It's not the Americans. It's not the Europeans. Who are going to India to get healthcare? It's the Africans, right? And the point that I think Dr. Thakkar mentioned, that our population of Africa is equal to what is India. So $7 billion is leaving this continent and going to India. If you add Thailand, if you add Turkey, if you add so many other destinations, I think Kenya has the human capacity, the geography, to get that those people who are traveling from neighboring countries to other parts of the world. So I think that is the role that the private sector can play. So that is number 2. And that will not only benefit those institutions, but it will benefit the country as well, because we are always in the need of foreign exchange, right? So that will bring in another source of revenue, and it is quite doable, number 2. Number 3, and this is, if I go back to a colleague of mine, Professor Mansoor, who is an oncologist, he always quotes His Highness's words, that when His Highness was here in 2010, he said that 2 things have been shortchanged in developing countries. One is education, the second is research. Because we are consumers of knowledge, we are never the generators of knowledge. I think we need to change that. I think, and that's where AKU is also playing its role. And we have just started. We are investing significant amount of money on research so that we can generate new knowledge. So there are 3 things. To summarize my answer, first is we have to develop human capacity more and more over a long period of time. And so it goes to all nooks and corners of Kenya. That's number 1. Number 2, we have to invest in quality of care so that people who are outside of Kenya can trust us. That if I come to Kenya, if I come to Aga Khan, I will get the same quality of care or better if I go to a hospital in India. So quality of care, number 2. And number 3, that we have to invest in research. I think these are the roles that the private sector can play, should play. And I think this is where, that's the role that Aga Khan University Hospital is playing. And I'll give you, and I'll just, the cost of care is expensive because the cheap is expensive. If you go to a cheaper hospital, they will charge you less, but what will be the clinical outcome, you don't know, right? So invest once, but invest wisely. And we see many patients who come to Aga Khan at a very later stage of diagnosis. And then the cost becomes very expensive. And the clinical outcomes are very challenging. So if what Dr. Olveni said, that if there is preventive care, then obviously the clinical outcomes will be better as well.
Okay. just before I come to you, I want to just ask Winnie, listening to, what Dr. Alwenya said, what Rashid has talked about, do you think it answers the question of cost of care to you as, somebody who's gone at the most expensive part of healthcare that we know in Kenya?
Yes.
Is it on? Yes, it's on. Okay.
Is it my voice? Oh, there we go. Yes, they have answered the questions and my concern as well. But I also wanted to add that I did fundraise even though I had insurance. I had both private and I had NHIF. But it's still quite costly. I have Jubilee, by the way. And I have NHIF. But Jubilee was only paying $15,000 at that time, some point last year into this year. The dollar rate was very good, so for me that worked well, especially when I was fundraising. That was very good for me. But even when you have, what my point is, even when you have insurance, private and NHIF, it's still quite costly. And I don't blame the owners of the hospitals, like everybody has said, or the doctors. I don't, but I agree that we need to find a solution because it's not possible for so many Kenyans. I also want to commend NHIF, even though it's been crazy. I ran out of my insurance cover from Jubilee, but NHIF has actually really helped because I'm currently getting an injection once every 21 days. And I have to get 12 of them. The first one was 250,000. My insurance and that's Jubilee and NHIF paid that fully. But after that, because I ran out of my cover, NHIF has been paying 100,000, and I have been paying around 67 the extra. So also NHIF is doing a good job. Sorry if you have had a bad experience. But I wanted to say that for some of us, it has worked, and I'm grateful for that.
Okay, it's good to hear from that perspective. Let me give Njeri just a minute to say something before we sign out of NTV.
Thank you, Winnie, for trusting Jubilee. I can start there, but again, goes back to the point of cost of care. At the end of the day, we will price insurance, and insurance has certain assumptions. Goes back to what Dr. Namit was saying, in terms of we have to go back to the inputs, and I think it's been repeated over and over again, to define what should be and I think we were having this discussion earlier, that no matter how high the cost of care goes, how much can we truly afford to pay? Because there's also how much we can be able to afford. And therefore, why our insistence continues to be, as part of funding, there's definitely the need for preparedness, because we can't all rely on WhatsApp groups. We mean well. We will want to contribute for each other, but I mean, life is pressing, and at times there'll be those challenges, and you can't put your life at risk because you can't afford to fund it. But again, the social layer becomes absolutely critical to be that first layer. But then insurance comes to be able to offer that. And you can imagine, perhaps if you look at Winnie's scenario, then from the onset, there was that initial care. What Rashid was talking about, from the onset, there are interventions. From the onset, there is care. And that is extremely important, especially for healthcare. Mm-hmm. It's not one of those things that you can wait, because then the situations become a lot more adverse. Mm-hmm. So it's that first critical layer and safety net as to how much we can afford. I think increasingly, as we discuss these aspects, the cost of inputs, can we have drugs? And for example, insurance companies will tell you 40% of our costs is pharmaceuticals. And it is because, I mean, and I will go to many aspects to that. It is actually the cost of care, but we must admit there's also the additional component of what we call upsell. Mm-hmm. When you go to hospital and you're asked, would you like vitamins with that? And would you like an extra paracetamol with that? I think we know our typical answer is yes. But the reality is that additional cost is actually added, and you're going to need it. Mm-hmm. So it is making sure that we have the layer that protects us. And increasingly for all of us, as you said, economies of scale, the more people are insured and the more we take care of the inputs, then therefore there's a real opportunity to bring the cost down. But again, it's not going to be an overnight opportunity. It's going to be some real work and a collaborative effort, both private and public sector.
Thank you very much for the panel. Let's give them a round of applause. We are just signing out of NTV. The conversation continues, so you're not going anywhere. It's because we're signing out of NTV for these live conversations where we're having a public forum really to discuss the cost of healthcare in Kenya, and we're trying to look at the myths and the realities that is our world today. On the panel was Winnie Kinda, who's a cancer warrior, Rashid Halani, the CEO of Aga Khan University, Dr. Tim Olwenyi, who is the chair of Social Health Authority, and last but not least is Njeri Jomo, who is the CEO of Jubilee Health Insurance. I was a host, Dr. Mercy Korir. We sign out from NTV, but we are still live on ntv.co.ke. On our social media handles, we are continuing these conversations, and obviously here with the panelists, we are continuing this conversation. So thank you very much. As we continue with the...
Yajayo katika NTCB Mobile Loan ni mkopo flexible kabisa na kwa viwango nafuu. Pata mkopo hadi milioni 1 kwa kiwango cha 1.2%, ulipe ndani ya siku 1, siku 7, siku 14, siku 30 au mkopo wa muda mrefu hadi mwaka 1 kwa viwango nafuu. Waweza pia pata mkopo zaidi wakati bado unalipa huu mwingine kila unapokuwa na mahitaji. Kupata KCB Mobile Loan bonyeza *522# au tumia KCB app leo. KCB, for people, for better. Sheria na masharti kutumika. Inadhibitiwa na Benki Kuu ya Kenya.
Kenya ni nchi ya mabingwa. Na
hapa hakuna shortcut.
Kuwa bingwa ni kujitolea, kujituma.
Mabingwa hutambua mabingwa wenzao.
Mabingwa hurauka kabla ya jua kuchomoka. Wengine kuwa mabingwa wa familia. Mabingwa huhakikisha tuna shine kama mabingwa. Wao hutulisha vyema. Ma-influencer wa kutuconnect mtandaoni. Mabingwa, wale ambao hutuongoza.
Sisi wote ni mabingwa.
Kijana hapo mbele, mzee hapo nyuma. Jamaa na jembe. Boda alimleta jamaa na jembe. Msichana wa kibao. Memba wa bodi, kijana wa maziwa.
Sisi wote ni Team Kenya.
Makofi to both baby and the new Morphix diapers. With its cottony soft texture and 3 times faster absorbent channels, the new Morphix diapers help to prevent rash. Morphix, comfy like a mom's hug.
Transplant. It can be an expensive affair if you're just looking at it as one hospital doing it. But if we're able to now look at multiple procedures being done within a facility, then you can actually package that particular operation or complex condition that you're dealing with. And again, the doctor's fee in that particular set can also come down, and other consumables can also come down. So I think we need to think about the more volumes we get for some of these cases, complex neurosurgical cases, and having more specialists on the team and looking at packages that can contribute towards bringing down the cost. Mm-hmm. Yeah.
So let me ask this question, because we get to talk about the cost of doctors when you're in the private facilities. But when you go to the public, you never get a bill with a doctor's consultation. And obviously the cost there becomes significantly less. So why is it that if I come to you, you'll slap me with a bill of a certain shillings, but if I find you in a public facility, you will just see me and you're still the same doctor?
So again, the reality is, again, the doctors in a public facility may be on a bench salary scale, okay? And the cost now in private practice now, the costs are higher because that may differ in terms of, the billing per day, for example, if you are an inpatient setting. And that now can accumulate if the admission is very long. Public sector, you try and provide, again, it's looking at the economies of scale. You want to try and provide a similar service. The doctor will be on a set salary. It's not a fee-for-service model, and that's where the difference comes in. So I think that the cost can be cheaper, but again, you may not have access to all the amenities that you require for that particular condition. And that's why you may have to seek more specialist care in other facilities. We are blessed to have some facilities offering, for MTRH, for example, Moi Teaching Referral. It's a public facility, but you can get a transplant done there. If you look at places like Coast General, also have very good care facilities. So I think the key thing probably we should be looking at is how can we eventually develop our public facilities. Kenyatta National Hospital, transplants are being done, complex neurosurgical procedures are being done, and the cost is cheaper. So I think it's just having access of good doctors who are able to provide that particular service, even to the common mwananchi. That I think is what we need to work on. So if we have more of our public facilities with well-trained specialists, then I think we'll be able to bring down that particular cost and offer quality. And again, same thing, having the equipment there. We've had this CyberKnife now in KUTRH. PET scans are also available in public facilities. So I think the more government can invest in equipment, in having these specialists who are trained, some of them have been trained out of the country to work in these facilities and are well paid, then we'll be able to bring down the cost at least and offer better quality even in the public sector. So it can work. Yeah.
I'm trying to read Professor Lukoe's face. I don't know if he's agreeing with you or disagreeing.
I'm disagreeing. Okay, thanks. So I'm disagreeing in the sense that the question you ask probably gives a wrong impression that the cost of the service at the public facility is lower than the cost in a private facility. So the price is lower, but we haven't talked about the cost. Because the cost of that service includes the salary that doctor is being paid, which is not reflected in the price. It includes the cost of the nursing care, which is not included in the price. It includes so many other things that are paid by the employer, by government, through our taxes, and so it will not be reflected in the bill. So if you go to KNH and you're admitted and treated by a team of specialists who are employed by KNH, when you get your final bill, you will not see the cost of a registrar. You will not see the cost of the super specialist who has seen you. You will not see the cost of the university lecturer who has seen you, because they are on salary. If you included those costs, you might find that the price would be significantly high, perhaps almost as high as in many private hospitals. But in the public hospitals, we pay a lower price because we pay the rest through taxes, and people get the salaries directly.
So would...
That's what I wanted to say, okay. And one more...
It's okay.
Besides the salary which are being paid by taxpayers, also the equipment. The PET scan that we talk about, or the CyberKnife that we talk about, and any single piece of equipment that the public hospital has is funded through the taxpayers. In the private hospital, the hospital that I manage, we spend close to 600 to 700 million shillings every year on buying medical equipment. So that 500, 600 million shillings is not coming from the taxpayers. It is coming from the bills that the patients pay. So that's what I wanted to add.
So would, say, having this doctors or specialists on a standard salary, even in the private sector, reduce the price that I pay as a consumer?
Will, if the doctors are on a flat salary,
yes,
will it reduce the price?
Yes.
I think we have to be mindful that the smell for pounds and dollars is better than Kenyan shilling. And we do lose people going outside. So if, let's go back to the example of cardiologists. If a cardiologist in Canada or in Australia or in other parts of the world is paid, let's say, $10,000 a month, and you want to retain the cardiologist, because like we said in the earlier conversations, that we have very few cardiologists. Now, if you tell the cardiologist that we are dropping your salary, they will say, I better go to Canada. I will have a better quality of life, better quality of education for my kids, better security, and the dollar is higher. So do you want to do that? Do you want to get into a trap where we start losing specialists? Although, and even today, we are very few of us when we talk about the specialists. So keeping the doctors on a competitive salary is the answer. Keeping the doctors on a lower salary is not the answer. And I think if you move the conversation away from doctors and move to the teachers, teachers are the ones who are educating the future for the country and all countries, right? And if those teachers do not have good quality education, good quality life for themselves, do you think that they will give 100%? Do you think that they will train our kids as if they are their own? They will not. So hiring a cheap teacher is not the answer. Giving the competitive salary is the answer. And to create competition, you have to train more and deploy more. And one institution cannot do it. Everyone has to contribute. And like Jerry said, that it is not going to be a switch that you turn out and turn off, and you have thousands of doctors and thousands of specialists. It's a journey, but we have to take that journey. We have to start training specialists and sending them into the counties. So no mothers suffers 25 kilometers from Nakuru, or we are not complaining about the doctors, because then there will be more specialists.
Okay. We had Dr. Ishmael, sorry. I want to give the doctors a chance to speak. Ishmael is here. Just to hear, he's a Gen Z doctor. He's a founder of Medics for Kenya, the ones who are being tear-gassed in town during the Reject Finance Bill. If you're wondering, I think at some point we had free Ishmael hashtag. Yes, that is Ishmael. He's free. So we want to hear from the Gen Z doctors and what their contribution would be in, making sure that we have affordable healthcare in our country.
Good evening. So first of all, thank you for the invite. I was told they require a Gen Z. Nowadays, every conversation has to have a Gen Z, and we love that. So yeah, so first of all, I'm a co-founder of Medics for Kenya, as she has said. Well, my partner is not available. So we realized that from the experience, there are a lot of medics, especially the mean age of around 30 to 31 years, who are unemployed. And we had over 2,500 medics who volunteered during Maandamano to help, free of charge, because they were unemployed. Some were not posted during that time for internship. So we realized that there is a lot of workforce that is not utilized in the country. For us, the Gen Zs, we are the majority of the medics in the country. I, for example, most of my colleagues who have just finished internship or who have finished internship, most of us are usually unemployed. It's a culture in the country where even our consultants usually tell us, "Mtavumilia tu." But that should not be the case. The WHO recommendation is 1 doctor per 1,000. In our country is one doctor per 5,200, which is 5 times inefficient. And we have over 187,000 healthcare workers only in the country, serving 54 million people in the country, which is very inefficient. So I feel like, in as much as our conversation is how we're going to run down the cost of health, I feel like the manpower and the demand and supply curve is very, very unfair to the medics, because we have the workforce. Around 1,000 to 1,500 medics graduate every year, but only a small percentage gets employed. So I, as a Gen Z, I feel like we have to be involved in the conversation, whereby for us to achieve UHC, we need to have doctors on the ground. We need to have nurses on the ground. In as much as we want to focus so much on primary health care using the community health promoters, I feel like if a community health care promoter, let's say, finds a mama mboga whose sugars are 23, if that mama mboga can't see a diabetologist on the ground, then the only thing we have done is identify that we have an issue, but we can't solve it. So I feel like that is from the employment perspective. We also have an issue where we are talking about specialization. Not many doctors can afford specializing in, let's say, the Aga Khan University. Most are depending on private and the public sector. And the public sector is not taking a lot of specialist students. We have very, very few specialists. And that has contributed to the brain drain. Because if I go to study in the UK, I wouldn't want to come back, because I know getting employment also is an issue. So I'll still stay there. So we have a brain drain issue in the country. So I feel like we need to address the demand-supply curve for medics. We really appreciate the fact that Aga Khan has started their specialization and subspecialization. We need more hospitals to come up with the same. We need the public universities to add more enrollment. We need the fee to move from the way they were. It was hiked to around 600,000. Public universities, as a specialist, for those who don't know, when you do your master's, you're not paid. So how many can afford to study 5 years without pay? And you're still paying school fees. So those are the issues that I feel like for us to tackle the cost of healthcare, we need to address them. Because the moment we have very few specialists, obviously the cost of consultation is going to be very high. Yeah, so I think that's the Gen Z contribution.
Maybe, yeah, you can allow me to just answer part of his question. So it's also good, I know specialty training is difficult to access in terms of opportunities and spaces in the facilities. But right now, for example, in surgery, we have programs now, we're actually training specialists in the public facilities. So we have COSEXA. At KP, we recently started the EXACOP program, where we're now training physicians in the county. That means if I'm from Migori, for example, I go to Jaramogi Odinga Teaching and Referral Hospital, and I do my master's training in medicine there. If I'm coming from somewhere in Eldoret, MTRH can offer that. If I'm coming from Coast, I go to Coast General. So at least now the opportunities that has expanded, for example, the number of slots for internal medicine. Before Aga Khan, probably we take 10 on average like this year. University of Nairobi will take another 20. MTRH takes 10. You're talking about 40 slots. As in EXACOP now, we now take 30 students per year working and are going to be trained in public facilities and at a much cheaper price of around 50,000 per year. So I think that's one, at least positive thing that's happening. COSEX has been running for years. COSEX orthopedics, neurosurgery. So I think programs like this also now targeting the public healthcare space. And these doctors will be trained in these facilities and they're going to remain in those particular areas. Will at least prevent this concentration of specialists in the urban areas. Just to give an example, I'm in diabetes. We have 22 endocrinologists in the country with only one out of Nairobi. So 21 in Nairobi, only one outside Nairobi. But at least now with the training programs, this will improve. Yeah.
Okay. Before I come to this side seems to be more active. I don't know what's happening on this end. I need contributions from this other side. So you can have a few hands up on this side as I hear Dr. Beverly and the gentleman behind you. Go ahead.
I'm Beverly, I work in neurosurgery. I think you've mentioned neurosurgery several times, so we are honored. Because I work in a procedure-based specialty, I want to ask the insurance companies to look at surgery in a different way. First of all, we can't train without equipment. You talked about you have to have funded whatever it is, and you are able to generate that money for equipment through volume of practice. One of the challenges we're having is when the insurance premium or whatever is being paid for that procedure is low, and therefore the patients either delay access to care or they find themselves shopping for care through different levels. And because Kenya is capitalist, you'll always find something at a price, but it normally comes at a price for care. So rather than being pioneers in good quality care, we ask what is the cheapest price we can provide X. And that is not without complications for the patients. It often results in not the ideal standard. So if we look at, for example, in cancer care, in brain tumors now, we're assessing people based on their immunohistochemistry, something that we can provide here. We happen to be one of the very few actually in the region who can do that. But the patient won't access care here because the person is looking at, this is the bottom line for price, and I don't want you to receive this for whatever reasons in the business model. I want you to go to X institution that may take out the lesion but not provide the holistic care. So that's one huge challenge about innovating and creating good care within surgical practice. The second one is if we want to be like India, we have to train in the country because we provide unique data. What does a population looking like us, living in our condition, how do they behave in a disease process? So that we can generate the papers and innovate on the procedures. But that's not possible without volume. And it's not possible to have volume that is constantly being shifted. Most of us see patients who subsequently go abroad, and then we're not doing the key bit, even when we have the training. It creates a problem for training. It creates a problem for skills retention. Because if you're a young person, you live once, you have about 20 years of a career. If you're going to live in a country that doesn't invest in allowing you to practice at the limit of your potential, then we are doing like our athletes. At some point, you'll say, well, I better move to X country because they will allow me to stretch myself intellectually. Then the other thing that you're asking about, how to bring down costs, better techniques will reduce length of stay. We need implants. Orthopedics has been revolutionized by implants, so has neurosurgery. Most of these are not costed at all, even within NHIF. So you find that they'll pay for part of the procedure, but not for that bit that gives you the winning edge in allowing that patient to have a better outcome, a shorter stay, reduced morbidity. So even as we're improving ourselves, we're asking for the financial models around procedural-based practice to expand its criteria and allow us to do more in country.
Mercy, I could read a few questions from the public.
Yes, I just wanted to summarize that for Njeri and also Dr. Oluwaye. What is your role in quality? Because we've been talking about cost, but do you have a role in quality? I think we can take a few, right?
Yes.
Okay, there was a hand up here. And then I want more questions from that corner. It was only Brian who has spoken, and because I called him.
So there's this one from the public.
All right, so one here and then I come to you.
So this one says the private sector is saying that it's expensive to run hospitals. Maybe this is for Rashid. So why can't you build smaller hospitals that you can run cheaply, therefore your charges will be less?
Okay, thank you.
That's a good question, and we are doing that.
I want to take a round, and then we answer all of them. Yes, go ahead.
Yeah. Thank you very much. My name is David Makomi, coming from the Cancer Civil Society space. I'm liking the conversations around the training of more specialists and investing high up. And inevitably, I think in conversations like this, we get very energized when we're talking about how much we need to invest in the tertiary kind of care. But another way of probably looking at it in terms of bringing down the cost of care is also having fewer people getting sick. Invest in the primary health care, what SHIF and the funds that are being set up, empower the populations to do what they can to not need a super specialist and to show up in time with maybe other symptoms of disease that will probably not need to come to Aga Khan, but that can be looked after in Njoro or in all those rural facilities. So if a woman is found to have some precancerous cervical lesions, that can be taken care of. But if she shows up with stage 3, stage 4 disease, she'll probably wind up in Aga Khan or in another a county facility, a tertiary facility that you need a lot more complex care. So if we have fewer people needing specialists because we have a strong primary healthcare base, strengthen the health promoters, health promotion officers, and all those sort of things, then we probably may need fewer. I mean, we'll bring the cost of care down because it's much cheaper. Thank you.
Okay, thank you. Let me come back. Let's start with Rashid and then Jerry and Dr. Oluwayin.
So thank you for the question. And we at Aga Khan, when I say Aga Khan, I mean Nairobi, Mombasa, and Kisumu, the network of 3 hospitals that we have, we are already doing that. It is not possible to build hospitals in every county or every city, but what we have done, that we now have close to 80 medical centers in different geographies across Kenya. And those medical centers, they are employed by us. Those are medics, medical officers. It has full-fledged pharmacy, lab, and the cost in those medical centers is 20 to 30% cheaper as compared to the main hospital. So those are not inpatient facilities, but those are outpatient facilities. Just to give you the stats, how successful that model is, the hospital on 3rd Parklands, Aga Khan University Hospital, sees 300 to 320,000 patients every year. Interestingly, the medical centers of within Nairobi, Rift Valley, and Central are now seeing more than 400,000 patients in a year. So what does that tell you? And that is mostly primary care. I think it touches on your question as well. That if you are seen closer to the home, which is 20-30% cheaper, which is more preventive in nature, then hopefully over a period of time, the cost of healthcare will decrease and you will need less number of specialists.
Okay, thanks. I think that's well captured, but I'll go to Dr. Lishenga to tell us if smaller facilities translate to, to lower costs. Let me start with Jerry. Do you have any role in quality of care, what Dr. Chesram was talking about, not just, the cost and, trying to negotiate that price down?
We definitely have a role, and I want to start where he left off on preventive care. And I know Dr. Oluwayin had spoken to it earlier. Incidentally, a lot of insurance companies are now addressing preventative care. We are only not addressing curative care. The one thing that insurance companies have is an African data set. We can show you disease trends down to, we really can have some good health data. So there's already a lot of work on telematics, early detection, and prevention. And there's already, we can have a whole conversation on that. But I want to go back to Beverly's question. And I want to give a sample. If you had 10 shillings, and I want to show you back to what Ezekiel had spoken about on adequate premium, adequate cost, and all of that, and why this is a big conversation for us. On average, you give an insurance company 10 shillings, 8 shillings goes to claims already, right now, as we speak. 10 shillings, 1 shilling goes to acquisition. Now, you're remaining with 1 shilling for innovation, to pay people, for marketing. Essentially, you have nothing. And which is why when you look at most insurance companies today, the actuaries will tell you they're loss-making. And that is with already just what we are charging. So that's how we end up with some limits within what people can already afford. So can we increase the limits? We can. The challenge, though, is then goes back to a consumer cost. And increasingly, we see more and more strain to afford and more drop-off. So it becomes such a tricky balance of how do we reduce this 8 shillings? And the challenge we have, and we can, I know Rashid and I speak a lot, doctors call us pairs. I would ask that you drop that. Please stop calling us pairs, because pairs suggests we have a big check. We don't. We actually end up paying out almost everything we receive. And that is what we have to figure out, which is why the cost of care conversation is significant. So can we increase the limits? Absolutely. The challenge is it's very likely that most people will exhaust their limits. And increasingly, one more insurance company goes under, another group drops off, another group drops off. And this becomes a bigger strain and a bigger strain. The cost of care conversation is real, because for us, our cost comes from the value chain. The value chain is what the hospitals already spend. And therefore, that is where the tension comes in. So can we charge more? Yes, but the consumers are unable to afford it. So we find a middle where we say, okay, what can we accommodate? So it's not so much about bottom line, because if it was about bottom line, I'm not even sure what we're discussing anymore. We have had conversations with the regulator. Actually, the regulator asks, what business are you doing? Because if you're all loss-making, what business are you doing? So we're at a very tight spot of trying to figure out how do we make this work. So it's not so much about not wanting to, it's that there's that tough tension in there.
So let me ask, before Dr. Olwenyi comes in, the proposal of SHA is that, the Social Health Authority through SHIF will be the first payer. And then, the complementary insurance kicks in. Would this help in any way?
I will say yes. And this is why. Most of the time, what you don't realize is, of course, there's the standard cost of care, which you already cross-subsidize anyway for everybody who you're contributing for in a WhatsApp group or the other, shows up as a cost through fraud. And I spoke about it. There's a significant level of impersonation. There is, because people give out. In fact, in Nairobi, it's not half as bad. Once you go to rural areas, everyone is sharing their card, right? So that cost will come back, and you see that is not priced in, and that strains it. But once you have a strong social layer, what it does is provide a certain level of care. Also, it makes sure that we are managing most issues before they get adverse. What you know is most people who get this card will give out their card, but possibly the person they're giving out their card to was already doing self-medication, was already taking antibiotics half dose because they couldn't afford, and then that cost increases the disease burden overall. So the social health insurance layer is absolutely critical to private health insurance really being able to achieve its intended objective.
Dr. Lui? Okay.
So, Dr. Olwenyi, I think I listened to you speak about the shortcomings of NHIF and that these new entities have come to fix those. The primary problem that I distilled from your presentation was a political one. That NHIF many times was being twisted to do things that do not make business sense. This I picked from you. How is this insulated in the new regime? How is SHIF insulated from the same kind of thing? How is that emergency fund, how sure are we that it is going to be budgeted for? How does that stand in the context of reject finance bill? So I think I need you to address those. Thank you.
Thank you. Maybe I can start with this question since that is the, I think the one that is more topical and easier for me to address. That was just one of the problems. NHIF had got a myriad of problems. That was just one of them. And I said the policies that they had were not properly priced. And then secondly, they were being offered by a powerful person. That's why I said in the Social Health Authority, it is actually enacted in the law. We are not allowed to manage enhanced schemes at all, right? So that is out. So at the end of the day, we'll have one benefits package, we'll have a contributors fund, and these other ones will be funded by the Exchequer. I know there are concerns, and there were concerns even within the hashtag reject finance bill, that first of all, we didn't get sufficient funds disbursed. But at the end of the day, these are two new funds. It doesn't matter what kind of resources we are given, it'll be additional compared to where we were before. And secondly, as a Social Health Authority, we have said we're going to be fiscally responsible. And this is going to be music to Brian's ears. We're going to promise only what we can pay for. Because the issue in the past was unsustainability. There's no need going out promising all these benefits packages, which can't be financed. And that's why NHIF owed providers a lot of money, right? So what we want to do, first of all, is to make sure that we collect the funds that are owed to NHIF, and as Social Health Authority, we've inherited all those debts. So what we're going to do is we want to collect the funds owed to NHIF, pay providers the full amount of genuine bills. Because that is, again, the second huge problem with the previous dispensation. We have not talked here sufficiently about medical harm, medical waste, and fraud. Dr. Wangia was making a presentation to us just the other day. It was yesterday in the morning. And she said, there are 3 cost drivers, 3 procedures in this country that drive costs. 2 of them, hip replacement, knee replacement. You can imagine those are one of the major cost drivers. These people with replaced knees and hips, how many of them do you see when you walk around? There's a problem. A lot of these procedures are not genuinely done procedures. And going to Dr. Brian's point, A lot of the procedures are done in a select few facilities. So if, for example, we're able to cut out the aspect of medical waste and fraud alone, that will release a lot of resources that we could be able to use to provide healthcare to Kenyans. I am not necessarily 100% in agreement that our solution is purely to train more specialists. Why do we have medical officers who are not employed? And we have got, our system needs them. There's a problem in terms of people are not deploying sufficient resources into the healthcare system. What are the reasons? One of the things I think is the problem is there's no policy stability. Anybody who is going to be an investor has got to be sure that they're going to get returns. And hospitals, he will tell you, a high investment undertakings. So we've had in the past, and this is one of the reasons why I said even before the association that I used to be Secretary General of before, somebody goes and invests in equipment, imaging equipment that costs them 50 million, 100 million shillings, and knowing that there's a market out there. Then overnight, a board sits somewhere and they say, now we're not funding any more private facilities or standalone facilities, we're not paying for MRIs. What are they supposed to do? So we have to encourage investments in the health sector, and policy stability is one of them. And I think one of the major steps that was taken is in terms of anchoring all these things in legislation. So it's not about a phone call, somebody calling and saying, do this and do this. We are not allowed to do it by law. Same thing with investing. We've had in the past where NHIF has invested in properties. We've got some land in Karen which was invested in many years ago, and it is not our core mandate. It's not our, so at the end of the day, even in terms of investments, we're not allowed to invest. All the funds that come into the Social Health Authority are going to be used to pay providers. And even we've got a cap of 5% on our administrative costs, which makes sure that we're going to be lead. On the issue of human resources, again, we have to optimize use of those resources. We will never have enough specialists to take care of our needs. That is a fact. What we have to do is make sure that those specialists are used to the maximum, so we can leverage on technology, for example, in terms of using telemedicine. But again, we're not going to have all those specialists everywhere. At some point, those patients, we have to streamline our referral systems and make sure patients will be able to move to places where they can get care. We can't have everybody doing everything. We have to have certain centers where we have got specialists, they do specialized procedures, and economies of scale will kick in, therefore costs will also come down. One of the problems we had with NHIF in the past was that there was this thing about saying you have to be a certain level to perform a certain procedure. So level 2, level 3. We had got specialists who came together to set up an orthopedic center. You're told you can't do the surgery because you are in level 3 and you need to be level 4 or 5 to do this procedure. At the Social Health Authority, our focus is on service. As long as you can deliver the service, and it's not our mandate to decide who delivers that service. The bodies that are mandated to be able to license and register, if you're licensed and registered to provide that service, then we will contract you for it. It doesn't matter what level you're on. Because at the end of the day, what we want to do is enhance access, and we want to get quality care wherever we can get it for our members. On the issue of cross-border contracting, the issue of going for treatment out of the country, it is extremely unfortunate, again, because a lot of the people who leave this country for treatment leave for procedures and treatments that are available locally. And that's how we're not developing our capacity. I had a discussion with a cardiothoracic surgeon once, and he told me he's frustrated because he's in the business of clearing and forwarding. Somebody comes in, they diagnose them, they need to do this procedure, they disappear. Next thing they do, they come back with a discharge summary and say, now please take care of me post-op care. We're not going to develop capacity that way. And so one of the things as a Social Health Authority that we will not do, we will not pay for any procedure out of this country which is available locally. That's the only way we can develop our capacity. And in addition to that, if there is need for us to be able to build the skills, let us have those specialists come in and work with our teams. That way the skills transfer, and in the end, we will be able to deliver those services locally. So the issue of everybody asking, oh, will I be able to go to India? That is not the priority. So we've got a benefits package and tariffs advisory panel which is going to be set up. It's a multidisciplinary team. They sit down, they see what procedures are available locally, and then what procedures we can be able to have done out of the country and treatments. And then as capacity increases, for example, if we get CyberKnife, it gets pulled off the list so that we can be able to develop local capacity.
I have 2 more questions here, but I think you've touched about something about fraud. Somebody is asking, how is SHIF going to deal with fraud, waste, and abuse that prevented NHI from reaching its full potential? And then the other one is, I would like to understand the position of the Social Health Authority on economies of scale in purchasing, leveraging on technology, and stopping the appalling levels of corruption.
As a Social Health Authority, we're in a very precarious position because as people come, insurance, she will tell you, is about trust. It's about somebody giving you something upfront and saying, when I'm in need, you will take care of me. Unfortunately, we are promising them a product which we can't deliver ourselves. We have to rely on partners. And that's where the aspect about having the other facilities stay robust and stay alive is important, because in the absence of medical facilities being viable, so I'm not for the idea of saying that we need to reduce necessarily how much people are compensated. It has to be worth people's while. Otherwise, even for private investors, they're in business for a reason, isn't it? So the key thing over here is to, first of all, to make sure that any treatments people get are justified. And secondly, we must get rid of fraud. So one of the ways in which we are trying to do that is enhancing fraud detection, surveillance and detection systems. I've always maintained the easiest way to get rid of fraud is for people not to benefit from it. The problem in the past has been, by the time the fraud is detected, the millions have left the stable. And in fact, the biggest problem why you say you got some top 100 or a certain number of people getting 70% of the payouts, unfortunately, those people who are engaged in fraudulent activity, their overheads are pretty low. Because if you didn't see a patient in the first place, you can be able to disburse half of that amount to somebody else who will get the money paid to you. So the key thing is to make sure through digitization, we're going to have end-to-end digitization. That's part of a larger government program in terms of digitizing the health ecosystem, so that we've got visibility end-to-end. Then we reduce the human interaction, human element in terms of component, in terms of managing claims, for example. Well, those are the ways in which we're going to be able to tackle fraud.
Okay, all right. I see Njeri wants to make a comment. Give me a minute. Dr. Wangia also, Macharia.
I'd like to add to...
Just 1 minute. I'm told we have Dr. Matolo who wanted to make a comment on whether insurance is a social good or not. I'll come to him. I'm just trying to figure out where everyone is so that it's easy even for the camera crew. Yes. So I think you can go first briefly, then we go to Dr. Matolo, then I come to my active audience on this side.
Back to your question on fraud, and I think it's something, as we said, as private insurers, we recognize the role of having SHIF work as it should. The opportunity that exists, because it's something that we do, is to also work with private health insurers. A lot of the things that social SHIF will be doing are things we already do, have learned, have had a steep learning curve, and already have strong learnings. And I'll borrow from the example of NHIF. Some of the fraud we were seeing, most private insurers will tell you, is actually what we'd call level 1 fraud. So there's a real opportunity for SHA to work with private health insurers. We recognize the role that SHA will play, but can we work together? Can we be part of that, round table? Can we be part of the conversations so that then we can support the agenda more from a point of, we have experience, this is an area we understand, whether it's a value chain and the opportunity, so that then we can fast track the opportunity that works. So that is one of the ways that we can manage the fraud. We have the learnings. We have, to a large extent, managed to address quite a bit of it. We can work with government and support them in being able to make this work more efficiently.
Okay, all right, thanks. Dr. Matolo, he's from Old Mutual and my former classmate and seatmate in medical school. The floor is yours. So you have a comment on insurance. Just go ahead.
Okay, thank you. That question is very difficult. So let me answer something different. So first of all, the way we are trying to do, especially for the social insurance, it starts being a public good, because we're talking about everyone being able to access that common pool, whether they are able to afford to contribute into it or not. Yeah, so I'd say the way we are doing the social health insurance can be called more of a public good. Of course, on the private health insurance, you're not going to be a member if you have not contributed premium, so that becomes a bit different. The discussion we're having today, I think one of the things that we haven't mentioned yet is a question around value, and value being defined by what outcomes are we getting for the money that we are spending. So outcome is a factor of the cost. So that if you look at what private health insurers are paying, we'll tell you that most of the time most of the money we are paying is actually going out to primary care. So managing basic ailments, and it's because of how we practice, especially within the private health sector. But on the other hand, we have all these patients who have, the more pressing healthcare needs, the patients with cancer, who will tell you that their covers run out very earlier on in the treatment. Yeah, but if we were able to have a rational discussion and see how do we move some of these funds, because a lot of the money we spend in primary care is actually wasted. So these are extra prescriptions. You go into hospital, you have a cold, you live with 7 different medications. We were never taught that in medical school. This is something around how, private healthcare is run. So that, if you're walking out of a private hospital with a big brown bag full of medications and you forget it in the matatu, you can go on and just continue with life and nothing changes. But if you're a diabetic patient and that happens, you will have to go back and look for where, how to sort that one out. So the discussion around value, we really need to have it. We need to see how do we move around the funds that we have so that we give everyone what they actually deserve. We need to spend more on the specialized side. We'll probably need to spend more on cancer. We need to spend more on, diabetes and hypertension, and spend less on the primary care. That's just what we are seeing this side. So then now the question around how we also pay for care, it's going to be almost impossible for you to get optimum care for chronic conditions if you are still using fee-for-service. We'll have to use more, innovative ways of paying, looking at chronic care models and ways to actually incentivize the healthcare provider to make sure that the patient is in good health. We are keeping away the complications, we're keeping them healthy. And we are able to reimburse everyone within a multi-speciality team. Right now, if a diabetic patient was to see everyone that they are supposed to see, that cost of care becomes unbearable. But if we come up with models that will actually work and we are reimbursing that team, then it becomes a bit easier. There's a lot written about that. It's just a question of all of us sitting on a round table and agreeing on a good way forward. Thank you.
Thanks, Dr. Matolo. And to come to this side, and I'd like us to just add 15 more minutes so that, we allow the hands that are up. So I'll ask that we make it brief. Professor Rosbella had a comment. Yes. So I'll start with Liz, then Macharia, Amit, Rosbella, and then Professor Mansour. And then I will wrap up from this side. I hope that's okay with everyone. Okay.
Yeah, okay. So thank you once again. So just looking at costs, it's very hard to tell whether a cost is high or low without actually going through the costing process. And this is one initiative that we attempted to do as the Ministry of Health by just looking at a patient journey and walking through the entire clinical pathway. Because at the end of the day, and I think Dr. Tim talked a lot around that, is around inefficiencies. Most of the reason why health is expensive is actually around inefficiencies. Looking at the payment, provider payment modalities that Dr. Elijah talked about, anytime you have fee-for-service, it gives the provider an incentive, it gives the patient an incentive. That it alone is an inefficient way of managing healthcare, and definitely the cost of healthcare will go high. So at the end of the day, my belief is that if we are to look at what exactly is the cost of health, we have to be deliberate through research, and mainly through research, we go ahead and look through the clinical pathways. What does it take to offer a certain service? So that if you make any changes, say if you change a drug from a generic to an original or a branded medicine, then you know that that particular cost center is what changes your overall cost. If you are changing the human resource from an in-house doctor Because as we did the cost of healthcare, we made some assumptions, like for instance, you must have, say, an in-house gynecologist who earns even, let's say, 1 million shillings. For them to do a delivery, it will take 30 minutes. And we cost those 30 minutes are based on a standard salary. And when you do that, the cost of that procedure actually becomes lower. Then we have now what you call the price or the tariff. Those are now the margins. But it's important to have the cost so that you know these are the costs. But if you want additional services, then we have to look at the margins. The other thing I wanted to maybe talk about quickly is around local manufacturing. When you look at local manufacturing, it may seem quite expensive to start with. But when you think of it globally, that first of all, you are employing the people. These people are paying the taxes. So if you look at it, I would say macroeconomically, there is actually a gain. In as much as at that point, you may think that it's quite expensive. So it's good to look at the situation by the two sides of the coin in terms of what is in it for the economy and what is in it just within the health sector.
Okay. As Macharia, you pick the microphone, there's a comment from the audience. Let me just open and tell you. So they're saying we should say that people should have one insurance per person. So that, for example, if you have Jubilee, then you shouldn't have SHIF. If you have SHIF, then you shouldn't have that one. So that the premiums you would have paid, say, for SHIF, goes to somebody else. And their reason is they say the private insurance uses NHIF to evade honoring claims.
Okay, thank you very much. I think I want to answer this question from an actuarial perspective. I personally had the advantage of being the first health actuary for Kenya. And one of the things I've learned in the last 10 years, actually, the most important thing is the cost per capita, the disease burden. Now, how do you price that disease? So the SHA uses something called, UHC is something called the rich pay for the poor. That's the SHA model. The insurance model is the healthy pay for the sick. Now, the way your social scheme will work is the more rich people you have, the more you can offer more benefits, right? And that's why it's universal, it's unlimited. Mm-hmm. And that's why you see people like SHA looking for the informal sector, looking for people saying, you need to contribute more and get them in the system. But there's so much SHA can do because, look, we only have 4 million employed people, and even if you add informal sector, the benefit SHA can give you based on that model, maybe it's 15,000 bob per person per year. It won't be much. Now you come to the insurance side. The healthy pay for the sick. So now the insurance companies have to go out, market, everybody come. But unfortunately, some people might not sign up. Most of the time it's the employers. And what does the insurance company do to stop the sick people from claiming more? They start putting sub-limits, right? So they put in those sub-limits so that the pool of money doesn't get exhausted. Now, unfortunately, these two realities are what we have to work with, right? Because Aga Khan won't change the cost of treating cancer tomorrow. It won't change, right? The insurer just needs to get more healthy people that won't claim so that the person who has a cancer can pay less, right? Mm-hmm. So the structure that SHA has will work for private if there's collaboration. And so for me, my parting shot is these three things. One, for healthcare to be cheaper in Kenya, there has to be some kind of partnership between the groups, right? There's a lot of segmentation, right? SHA has the power of everybody pay, right? The insurance companies, remember, need that so that they can get the healthy to sign up, so that they can reduce their claims. And obviously, SHA needs more people who can pay more than the rest. That's number one. Number two, we need to go to long-term financing. This financing of 1 year is not going to work for us because 1 year financing means that if I'm not sick, then renewal. But if you go to what we call post-retirement health insurance, where you pay for 10 years, 15 years, you're contributing into a scheme, what that means is that now we're like, wait a minute, if I'm going to contribute to this scheme that will pay me will pay for my care when I'm retiring, then all of a sudden I'm like, okay, actually I need more Gen Z doctors to be employed. So I'll say, this money I've put, because the post-retirement scheme is like a pension scheme, you'll say, okay, this money I've put, don't buy bonds, go get hospitals, finance doctors, blah, blah. So the long-term financing conversation, there's a time we started it with the team, so I'm sure NHF will be part of that discussion in SHA. So that's the second layer there, long-term financing aspect. And it's the same amount, just that instead of buying bonds, you now invest in healthcare. Then the final point for me that I feel really will change the cost of care today is hospitals of offering a service where it's like a disease-based capitation. Now, if they do that, then they will manage the consumer, because the problem right now, our fee-for-service model, is driven by the fact that the consumer is expected to know where the best hospital is. They don't know. If you tell everybody in Kenya you have a card, go anywhere you want, and then you tell them, okay, you're sick now, you have cancer, where do you go? Do we really think this person on their phone will know which is the best doctor to know? They don't know. So we have to go to a model where now the hospitals offer that service, and then the insurers vet those hospitals and say, okay, you are good at diabetes, let's push all the diabetes traffic to you. What does that mean? The doctor salary we're talking about, if you can see 100 patients, maybe you can see 150 patients. And with the same salary, we're able to reduce our cost. And also, the people who are importing drugs and now know they're importing a larger bulk. So the whole ecosystem today can be addressed if the hospitals give capitation services, disease level. Not those ones for 500 bob and I'll treat you even for head transplant. No, specific, like surgery for this, I will provide you at X amount. And that will reduce the cost of care. Otherwise, if we are still segmenting, nobody is talking to each other, we're still financing for 1 year on our insurances, and the hospitals are not giving upfront payment on capitation, then we'll still have the same challenges. Thank you.
Okay, thank you. Dr. Amit?
Yeah, thanks, Mercy, and thanks, everyone. I think the formula for reducing cost of care in Kenya, from where I sit today, listening to all the experts, seems to be clearly defined by the 3 C's. And the solution, one point that I want to leave behind for us, which I think has never been brought up in today's conversation. So the 3 C's are care workers, commodities, and claims. One, we need to increase, and the other, we need to reduce. As far as the care workers are concerned, the doctor talked to us about we are 5 times less than what we need. And to produce health workers is a tedious task. So you know how long it takes. And all of us who are in this space know it takes time. So I'm going to come to that. It's going to be difficult. And the healthcare worker population ratio in the world is increasing. So that's care workers. The second one I talked about was commodities. And that's an area where when Winnie talks about the 585,000 and everything, we need to start reducing it. And the roadmap from Turkey, India, Thailand is all the same. You saw them over the last 30 years. They focused on commodities, and every cost came down. Look at ARV. What was HIV cost when we started treating HIV? And look at it now. So there is absolutely no brainer that the second C we have to reduce. The third one, I think Tim and Jerry mentioned, is these claims. Somebody pays for fraud, by the way. Guess who? Whenever a fraud happens, and any fraud that happens today, guess who pays? Is it the hospital? Is it the staff of the hospital? Guess who pays for the claim? Patient.
The patient.
Every fraud is paid by Kenyans, and every shilling is affecting households. If anybody commits any claims, fraud, the cost is transferred straight to the people who want to get risk covers. So I think the 3 C's are clear. One point I just wanted to mention, we may not have discussed it adequately, is I think Rashid mentioned very clearly research. And here I want to bring technology and innovation. I think we all have touched it. But AI is something that I think will be the secret sauce in a few cases of reducing cost. Many years ago, it was raw materials and producing medicines and producing doctors and health workers. AI is going to reduce the cost of a neurosurgeon by a huge margin. AI is going to reduce the cost of the radiologist by a huge margin. AI is not going to replace doctors, but the doctors that don't use AI are going to be replaced by doctors who use AI. And that is a transference of a cost-effective healthcare model to the household. It's going to reduce your claims. You will have less waste. Do you know those repeat visits that go regularly, and that chews up a huge amount of money is going to reduce. Do you know those misdiagnoses that make households poor is going to reduce. Okay. The waiting time is going to reduce. The efficiency. So I think we must seriously, as Africa, because we don't need to look anywhere else for our solutions. Okay. We need to constructively and effectively design AI and technology to bring costs down for about 1.4 billion people. Thank you.
Thank you very much, Dr. Amit. Roseboro, absolutely have a comment on preventive care.
Thank you so much. I think for me, I want to highlight that from a population health perspective, when we think about investing in promoting the health of the population, you have to emphasize on the entire spectrum of care, from health promotion all the way to palliative care. And what we've seen in our efforts in the population is, there's a huge gap in terms of knowledge, what it is that is actually driving disease or death within our population, where people should seek services, as was rightly said before. But I think what hasn't been mentioned is the fact that we need to see the health sector investing in all the other sectors that influence it. Safe and efficient food supplies, because amongst the 10 risk factors that we see driving disease burden are still things like diet and nutrition. We still are facing issues culminating from, inefficient water supply challenges within our population, water, sanitation, hygiene. So, seeing the health sector present in all other sectors, whether it's education, environment, is key. But also adding on to the mention on research and technology is leveraging data and digital solutions. So for instance, one of the key things that we're seeing is the important role that community health workers are playing, because they actually touch base with people for the community health units that are functional, that is, at the household level. So it's the biggest strategy in terms of ensuring that you don't miss people. And they're collecting significant data that we're able to use to say, these are the priority areas that we need academia, for instance, to be researching on. So focus here so that we're able to find some solutions.
Mm-hmm. Okay. Thank you for that. Looking at the other areas that affect health, Professor Mansour. And then we'll wrap it up with the panelists here.
So thank you, Mercy. I'm an oncologist. My name is Mansour Saleh. I work at AKU. And I was compelled to say something because everybody's talking about cancer. I trained in America, but Kenya is my home now. The discussion I hear is the same discussion we had with Blue Cross Blue Shield, Medicare, Medicaid. And I talk about what Rosabella mentioned about research and what was mentioned about AI. Professor Lukoy will agree that 98% of AI database is made of white men and women, not Africans. Before we use AI, whether it's in pathology or radiology or in patient care, we have to contribute to the knowledge base of the AI that looks at us, people who are us, and genetic makeup that is us. And I think that is where research is very critical. I also want to point out that primary care is not preventive care. We will eradicate cervical cancer, which is the most common cancer in women, if we did HPV vaccination. I'm not sure whether Jubilee or NHIF or SHA funds HPV vaccination. We would eradicate breast cancer by 2/3 if we had mammography free of charge for every woman above the age of 40, or colonoscopy for a man who's above the age of 40, or PSA testing. I would like our individuals, and we talk about this in the US, we can reduce the cost of care by at least 23% if we improve prevention, but clearly early detection and things which we know work, at least for cancer. The other third, we can improve in the cost of care of the last 60 days of life. In cancer, at least 40% of the patient's care is lost in the last 40 days of life, where clearly care is futile. Those are things where capitation might help, but I believe we should hear how we really want to prevent cancer by really contributing and investing in early detection, which I believe at the moment we're not doing, because that would solve significant problems. And in terms of research, yes, we should do that because we are not represented in the knowledge base of the world at the moment, and we need to make a difference.
Great contributions there. Thank you very much. I want us to wrap up from the audience here. Widi, you had a comment to make, and as you wrap up, having had everyone, including Dr. Olwe, do you think the proposal from SHA will resolve a lot of the issues that we've talked about?
All right, thank you. Before I answer that, I'm going to agree with Dr. Mansour.
Yes.
About research, which a few other people have said, because so I was diagnosed with breast cancer. I'll try and make this very quick. And one of the things that I had to do was a BRCA test. And the insurance did not want to pay for that. And the problem is, this is a very important test. And when I eventually decided to just do it anyway, I had to send my sample to the US to get that test done. And they thanked me. They said, we really appreciate that you did this because we don't have enough samples for Black women, African women. And that's terrible, because then how do we treat Kenyans, Africans, if we don't have money put into research? So I agree with you, and I agree with everybody else that talked about research. We need to consider that, and please, insurance, pay for that. My other question was about NHIF and SHIF. Can I call it that?
SHIF, yes.
SHIF, yes. Because there was a concern, and I'm speaking on behalf of people who have chronic illness. What happens to people who have paid for NHIF, like I have, and NHIF is very helpful for me right now. What happens during that transition? Are we going to have a problem where we are now stuck somewhere in between? Do I now start paying for this other one? Is this other one going to continue? Is my money for NHIF going to be transferred to this new one? I would like an answer to that, and I forgot your question. I'm sorry.
No, you answered it. Yeah. Will it resolve?
Yes, the problems.
The problems. Okay. All right. Yeah, that's it. Let me go to Rashid. Just your parting remarks, and whether you think the proposal by government would resolve many, if not all, the issues that we have.
That's not a question for me. But if you ask me if I stand up and walk, it's not only about the two legs. My eyes have to support it, my spine has to support me. All these things will make me walk. So when we talk about will SHA, SHIF work, every player in the play has to play a role. The private sector has to play a role. People who are importing commodities, they have to play a role. There are providers in this market who do not have an MRI but bill for an MRI, and NHIF or SHIF reimburses them. The fraud that we were talking about. Insurance have to play. So all these players, they have to come together for this to work. The government have to play its part. Dr. Olwe mentioned that the first and the third fund, the primary care fund and the emergency and chronic fund, will be funded by the taxpayers. It has to come through. So all these things will have to work together for it to work. And time will tell. What I can say is that we will play our part. We'll play our part in providing good quality of care. We will play our part in providing good quality education. And we will contribute to the local as well as global knowledge.
Okay. Thank you very much. Dr. Olwe?
Thank you very much. Just to answer her question, anybody who is a current member of NHIF, their contributions are going to be transferred already as it is a social health authority is the owner of those funds and the liabilities and the assets. So either way, at the transitional point, you'll just move to the Social Health Authority under the Social Health Insurance Fund. Any premiums you've paid in advance, whether you've paid in advance, will be prorated and you'll continue. One of the things we're paying a lot of attention to is the transition period. You realize this is a very sensitive and emotive area. And sometimes I feel it is refreshing because when I get a lot of animation and criticism and so on, it means this is important. And everybody knows it is important. NHIF, despite its shortcomings, is extremely important to the lives of everyday Kenyans. So one thing we'll not do is to jeopardize the quality of service as we transition. People have asked, why do we keep postponing the deadline? I have said repeatedly as chairman, I would prefer to do this right and do it on time. But if I had to choose between one of the two, we will do it right. So even if it comes to 1st of October and we are not ready, we will still push that deadline. We are doing everything that we can. But at the end of the day, I want to allay the concerns that a lot of Kenyans have. Any benefit that is offered currently under NHIF is going to be at the bare minimum, maintained or enhanced. In addition, we're going to have additional benefits, and regardless of what resources we have from government, and you know the economic realities at the moment, we might be trimmed down the benefits package for these other two funds from whatever we anticipated, trim them down a little bit. However, worst case scenario, what happens? We're slightly better off than where we were. So I want people especially to allay these concerns that people have about, is it going to work, is it going to not? We're going to be slightly better at the worst case scenario, we'll be slightly better than where we are. We have acknowledged the system was not working the way it should. And especially for most Kenyans, it was not working at all, right? For the people in this room, possibly, it was working to a fairly good extent. For a lot of Kenyans out there, it is unacceptable. I remember even on social media at that time, I was saying, some people are saying, imagine SHA wants to pay, I don't know, only X amount for a dental extraction or for whatever. You must realize there are many Kenyans in this country who have never seen a dentist in their lives. And if that is going to help them to do that, it's a start, isn't it? There are a lot of benefits which didn't exist, which are being offered in the new package. So I want to reassure people that, first of all, we've got a team. So the problems we had are very clear. I've delineated those. The solutions were crafted. They were anchored in legislation. We've got a management team that I believe is competent to deliver on this project. The execution is going to be disciplined. So as far as I'm concerned, this project is going to work. The question is how well it is going to work. Thank you very much.
Thank you very much. Njeri, your final comments?
Thank you. I think that the dangerous thing about healthcare is it's an emotive conversation, and we're trying to have it rationally. And that's where we find ourselves in a difficulty. It is someone who walks into hospital and wants to get treated, and there's a financial implication. It is someone who calls us as insurers and tells us, have a human heart. Take up my bill anyway. And that's the reality of the real need that exists. For us, and I'll continue saying this, healthcare is both a public and a private good. It will take both of us. It will take all of us to play a role. It will be government, yes, with a universal healthcare layer. It will be government creating an enabling environment for manufacturing, for generics, creating policies that helps us stop prescribing Mercedes-Benz instead of Toyota. Can we for once prescribe the formula and not prescribe a brand, especially when we do drugs? And that's policy, and that begins to inform cost. Can you give me the cost ranges? Let me choose. This is an antibiotic. Don't tell me this drug. Tell me this range, and let me address the issue of cost. It will be private sector, and for us, especially as insurance companies, keeping our promise and doing what we committed to do when our customers signed up. It will be for the medical professionals. We're discussing fraud, holding themselves accountable for misdiagnosis, holding each other accountable for repeat visits and unscrupulous behavior. We know these things, but where is that accountability? It will be for the private hospitals and getting more efficient. It will take all of us. And at the end of the day, because this is at the very center of human dignity, it really is not going to be one of us. It is actually going to be all of us.
Okay. Thank you very much. Let's give everyone a warm round of applause. It's been quite an engaging conversation, and what I'm taking home is that we need to talk more amongst ourselves, not insurance having a conversation, or government or private sector, but we all need to, talk with each other and contribute to the solutions, because as you hear, we have all the solutions in this room. So thank you very much to my panelists. Thank you to everyone who's been a part of the conversation, both here physically and online, and I appreciate that. It's been an honor, being a host of this conversation. Allow me to invite Kagiri, Anthony, he's here, to close so that he can tell us what next or where we go after this.
Thank you. Thank you, everybody, for coming. Every time we do these conversations, towards the end, we have to stop people. So I think it's like a jiko. It's beginning, you're trying to perpetuate the conversation, then everybody wants to speak, and we have to pour water on it. We are very sorry, and sometimes I am the one who has to tell the moderator time is up, so I'm very sorry. But we want to, on behalf of the organizing committee, I want to say a great thank you to everybody who made time to come. And this, every time we do it, we say this has been the best. So this again, the seventh one has been the best. I think the most attended, the most conversations, and we'll definitely do it again. So the Dean has noted, he pays our bills, and he has said we are doing it again. So we will have the next one in November, mid-November, we'll do another one, and it will be on something different, and we want to welcome all of us to come. Those of you who came in with a car and you parked at the basement, just drive out, ensure you have the ticket. The guys at the gate will need that ticket. So give them the ticket and you will be let out. We have tea at the ground floor because we want you to continue speaking. We see you will still want to go on talking. So go downstairs, you can talk to Professor Mansour and he can tell you what he's doing to increase the number of black people, the rest of us in the research sector. To appreciate our panelists and our moderator, we have some gifts, and I want to welcome Pauline. Pauline Gatia is our director for marketing at the hospital to offer this gift. And we will start with Jerry. So you just come here for the camera people. Let me just... So thank you so much for coming. And it's just a token of appreciation to remind you that we like you and we love you. Thank you, Jerry. And hopefully you will lower our premiums next time when we come. Dr. Olweni, thank you so much for coming. This conversation would have not been as good as it was if we didn't have government here telling us what they're doing and us putting it on the spot. And I'm very happy because my day job, this is not my job, this is my side job. My day job is to tell people how good Aga Khan University Hospital is, and they always ask me, why is it very expensive? So the guy who signs the check has explained to you how it is expensive. So let's appreciate him, Mr. Rashid. Thank you, Winnie, for taking time. Some may not know that you are actually across the road for a procedure and you made time to come. We really appreciate that even as when you're unwell, you came. Thank you so much, Winnie. And to the doctor who decided doesn't want to treat people, he wants to speak up, to join our world of communications. Thank you so much for closing the floor and joining us, and thank you for moderating this so well. Once again, I appreciate all of you for coming. I appreciate our staff from the Aga Khan. That's mine. and Pauline has decided to give away my gift. Thank you so much, Taka. Thank you very much. Thank you so much. Okay. Thank you so much. So all the expert audience, all the expert speakers, your gifts are there. You will receive them. You will receive them. You're expert. So this convention is very interesting. We have panelists and expert speakers and the rest of it. So you will get your gifts as well. So thank you so much for making time. My colleagues at Aga Khan University and the members of public and the speakers, we really, really appreciate. And now I welcome you to have a cup of coffee downstairs and enjoy. See you in the next one.
Thank you.
Up to 1 million Kenya shillings from as low as 1.2% with a top-up anytime you need. Dial *522# or apply on the KCB app today. The KCB mobile loan. Unbelievably flexible, incredibly affordable. KCB, for people.